Assalamualaikum, good afternoon. Okay, I'll cut this long story short. No lung cancer screening currently available in Malaysia. That's a fact, okay? Right, but obviously we need to try and address, because lung cancer is one of the major cancers in the world. Obviously it's quite high incidence in Malaysia, and we're just going to go through it and what can we do. Because what I'm representing a Lung Cancer Network Malaysia. We've been around since 2018, NGO managed by small groups of doctors, physios, dietitian, palliative care, and oncologists. Okay, very close group managing this. Next slide, please. Okay, so we know lung cancer is leading cause worldwide. Lung cancer, we have up to 2.09 million, about 40% of whole cancer worldwide. In Malaysia, 5-year survival is only 11%. Next slide. So approximately 10% of all malignancies, lifetime risk is in Malaysia, okay? 1 in 55 Malaysian males. Risk is highest in Chinese males, 1 in 43, followed by Malays and Indians. For women, risk is 1 in 135. So it's predominantly a disease of males, mainly associated by smoking. So majority of people who smoke are men. But the thing is, the incidence of cancer actually is in women is rising. So it's rising because those are the lung cancer that's not associated with smoking. So that's the one that gives us some headaches, because obviously in those who are smokers, then we talk about cancer screenings, but those who are non-smokers, so how do we count, how do we assess whether their risk is high or low? So the age standardized incidence rate of lung cancer increases rapidly after the age of 45, highest in 60 to 74. And majority of cases, up to 90%, we picked up normally in stage 3 and stage 4. So why is this? If we talk about breast cancer, you can do self-test. So because you can feel it, so superficial, okay? Lung cancer, so lung is a huge area. So let's just say this is your lung, okay? So you develop a blip here. So that's not cause any problems unless you start to invade blood vessels, causes airway obstruction. So you have a bit of infection, cough, yes, you will pick it up. But predominantly it's going to grow bigger before it starts to maybe causing pain, a rib cage, invade a blood vessel, cough, infection, etc., etc. So that's why predominantly we get patients presents quite late. And people, as you know, Malaysians, that okay, they get certain symptoms, or tak apalah, we're going to go to the shop, we get honey, we get our ninjo, cough syrup, stuff like that. We're going to go to the Chinese medicine shop. So we've tried the conventional one, we do the non-conventional one, and that drags on and on and on. And then obviously the family members say, oh, or the friend from the surau said, okay, try this one, try this one, try this one. Before you know it, it's gone 4, 6, 7 months, and then presentation is late, and we can't do much about that. So I mean, this is really the reality that we see. Next slide, please. So, so this is from Journal of Thoracic Oncology. This is Malaysian data, okay? Just showing that the presentation is quite late for both men and women. So 3 and 4, so quite late in the day. Next slide. So everybody talks about smoking. Okay, so smoking prevalence in Malaysia is still high. 50% of adult males we're looking at are more or less smokers, and more than 90% male lung cancer patients have a significant smoking history. So when we talk about significant smoking history is more than 20 pack years, so 20 a day for 20 years. And nearly all young female lung cancer patients are more or less never smokers. So these are usually, when it's picked up, that we're seeing that almost all of the cases are adeno-CAs, adenocarcinomas. Next slide. So again, survival is poor, predominantly because of late presentation. When they present late, so limited, okay, they are very poor health, that you can't have chemotherapy or treatment-wise. But if they are appropriate for certain targeted therapy, then they might last for a bit longer than what we used to have 5, 10 years ago. So, I mean, that's one problem. So the thing is, when they present to the GPs as well, sometimes what happens when we see our patients that they present to one GP, the GP try to treat the patient, they see once, twice, the GP is not good, I'm going to go to another one. So they jump around. So that's actually quite good where if you have a good primary care system like the UK, so you can't just simply go and see a different doctor all around. So they do that, and they don't tell occasionally that they've seen somebody else. And occasionally the GPs, they don't do x-rays early enough, or try to then refer the patient. So by the time they refer a patient needs a chest x-ray. After that, they need a CT scan. So if you go to a government practice, getting a CT is a nightmare. Okay, so it just takes quite a long time. So if you go to private practice, obviously a bit quicker, so we can get things rolling quite quickly. Next slide. So as you can see, survival for lung cancer is very low. So again, presentation and survival is affected. So the later the presentation, the survival goes lower, high mortality. Next slide, please. So these are cancer cases. Again, so lung cancer still accounts for quite a high number in Malaysia. Okay, the third commonest in the country. Next slide. So typical signs and symptoms that we see: a persistent cough, shortness of breath, fatigue, wheezing. So we do find weight loss, but the trouble sometimes patients don't really volunteer. And it's best that if you have collateral history from the family members, occasionally they wouldn't notice that they've lost a bit of weight. Coughing out blood is quite a late presentation, usually almost like TB. Everybody talk about coughing out blood, TB, but it's not that common, really. So recurrent lung infections, bone pain, etc. So most people are at risk are above 40 years old. So we're going to screen them, 40 years old, heavy smoking history, possible history of lung cancer in the family, or strong cancer history in the family, exposure to air pollution. Nowadays we talk about particle size of more than 2.5s. So high exposure. So I suppose that when we had COVID, everybody was using masks. Maybe the incidence of lung cancer would have dropped a little bit. Okay. History of lung disease, those are things like COPD, those with lung scarring. Also, there's a slightly higher risk as well. Next slide. So we need to have early detection. So obviously the main thing is getting patients screened, educate them, try to a bit more. Try to care a bit more about their symptoms. But the trouble is, again, Malaysians are a bit stubborn. So if you as a family member have told, say the spouse has told the others, say the husband or the wife, go and see, hey, go and see, and sometimes they just don't do it. The same thing as we as children, if we ask our parents to do it, also is a struggle sometimes to get our parents to go and get screening done. So, but I think sometimes we do have to push a bit harder. Next slide, please. So early detection, so we talked about low-dose CT. Low-dose CT in Malaysia failed. Why did it fail? Because we could not get the right population to go for screening, and the KKM just can't cope with getting CTs done. I mean, that's why it failed. Not to say that because the data was so poor, okay? Because most of other countries, they just show some benefit, okay, from doing it. So if possible, low-dose CT will be the best, okay? Low-dose CT, there's no contrast. CT scan is slightly more than a chest x-ray. So you can do a low-dose CT on average for the high risk, get it done every year. Okay, next slide, please. Can you go next slide? So this is just symptoms again I mentioned. Next slide. Less common symptoms will be finger clubbing. Medical student loves this, okay? Finger clubbing, so the whole class will go and find and look at the patient's fingers. Luckily, they don't have to do anything much apart from just looking at it. Okay, right. So this is quite bad. It's almost what we call a drumstick appearance. Okay, they can get some swelling in the face, hoarse voice, etc. Next slide, please. Okay, X-ray abnormalities. Most common test probably done apart from blood test is going to be X-ray, a chest X-ray. Everybody here has had one chest X-ray done in their lifetime. I'm fairly sure of it. Okay. Right, so it's been around for more than 100 years. Okay, obviously quality, doing X-rays, and the amount of radiation trying to do when you're trying to do an X-ray is much lower now. It's the same. If you walk around whole day, the radiation exposure from the environment is the same as one X-ray. You can get one X-ray every single day for the rest of your life, and you'll still be alive. Inshallah, hopefully. Okay. So what we found, what we've done recently in collaboration with the GP practices and also with AZ is that we've done AI-assisted chest X-ray reporting as well. So the GP practice was doing it for employment screening as well. So what we, the abnormal people with the X-rays, we offered them to get CT scans done. but unfortunately the take-up rate is so low. So again, not to say it failed, but pick-up rate is so low after that because one, can't get days off work, two, fear of getting diagnosed. Okay, but it's even worse if you get diagnosed and you can't do anything more after that. So everybody will be affected by that. Next slide, please. So this is just an example, right? So we have somebody with a swollen area here. I just had one lady recently. The only problem was joint pains. Had an X-ray, swollen superior mediastinum, and we did a CT scan, swollen neck, nodes here, nodes here, nodes here as well. Could have been lymphoma, could be sarcoid. All right. So this one, you can see this is a guy with an emphysema. Obviously, you can see the left lung is not normal. And this is a person with an abnormal lesion on the right lung. Next slide, please. So this is an article that we published anyway recently, just based on the AI imaging. So trying to detect and just try to give an algorithm for possible lung cancer screening because there's limited access in the government sector to get CT scan. But obviously, if you go to a private hospital, you can probably walk in and get a CT on the same day. Again, it's very quick. Will last for just a few minutes. Go in, get the pictures. It takes longer for getting the report. So I mean, when my patients go for a CT scan, I look at it myself. I do wait for a radiologist just to confirm my finding because I might have missed something, that's all. Next slide, please. So low density available, predominantly in private institutions. Again, the pilot study screening was previously introduced, but the pickup rate is so low. Okay, next slide. Useful tool, screen criteria 40 to 70, 25-year history, a current smoker of less than 15 years smoking. But there's been some data to say that even though they've stopped smoking for more than 15 years, the risk is still there. Okay, next slide. So conclusion, again, poor survival, we need to we're trying to educate more patients or people around to get screening if they're high risk. We've had recent event in KL as well. So I think we picked up 2 abnormalities that we sent in for CT scan just to have a look and see what was going on. So fortunately, it looked quite okay, those CTs. So medical advice for consultation investigation, high risk to go for CT, but AI chest X-ray might be something that we need to be looking into. I think KKM with our ministry as well. I mean, he's looking at that and probably something that we're going to explore in the very near future. Thank you.